Thank you, Kareem. For the next few minutes, I'll be talking about multimodal analgesia, including opioids, after hip surgery. I have no disclosures. And I think that we've all seen these startling statistics about the opioid epidemic in the United States, with over 130 Americans dying every single day due to an opioid overdose. But this is really a worldwide problem. And while we focus primarily on the response in North America, I think we've seen from our partners around the world that every single country, every healthcare system has been trying to intervene to curb the overprescribing of opioids. And this guidance that came from MHRA affects the UK. This just was issued in the fall of 2020, and it provides a number of different items that serve as advice for healthcare professionals. And some of these are fairly specific. And they describe the use of opioids for short-term pain. And they talk about the risks involved, in, especially with regard to opioid use disorder for patients who are prescribed opioids. And it's also important that they recommend for healthcare professionals who prescribe opioids that they counsel patients on the treatment strategy, as well as the risks of overdose and advice as far as safe storage, disposal, and cessation of opioids. I think as anesthetists and surgeons who take care of patients having elective procedures, we recognize that persistent opioid use is one of the most common complications after surgery, and even minor surgeries can lead to long-term opioid use. When we look at the patterns of opioid prescribing, which you can see on the right, surgeons prescribe the majority of opioids for patients having surgery for the first several weeks, even up to the first few months after surgery. But at the point somewhere around past 3 months, at least here in the United States, those prescriptions get taken over by primary care physicians. And that's how long-term opioid use can continue. As you can imagine, our opportunity to intervene in terms of opioid overprescribing for every surgery type, not just hip surgery, is really represented in this time after surgery, post-discharge for the first several weeks. And so our focus more recently within our group has been stretching out the acute pain service to try to cover more of pain management, not just after surgery in the hospital, but also at the time of discharge and post-discharge. And as you all know, there has been little practical guidance and education for clinicians on how to consistently implement opioid tapers. We don't have the evidence to support many of the recommendations. And unfortunately, many of the regulations and laws that tend to guide our practice have been done primarily as a reflexive response to the opioid epidemic, as opposed to emerging evidence. So if we were to go back in time and try to figure out, well, how are we going to make recommendations for patients on how long they should take opioids, then it really should start with how long pain lasts. And these are data that we pulled for a publication last year, looking at randomized clinical trial patients. So this is a fairly homogeneous group of patients with very strict inclusion and exclusion criteria from a single academic center. And looking at the patterns of pain with movement over time, you can see from these 4 types of surgery, knee arthroplasty, hip arthroplasty, mastectomy, and shoulder arthroscopy, that the pattern of pain resolution, or the trajectories of pain for this particular patient population, is different based on the type of procedures. So these patients were relatively similar, and you can see that knee arthroplasty patients tend to have moderate pain, at least moderate pain, for about a week or more, whereas the hip arthroplasty patients have a fairly steep trajectory over the first few days after surgery that is not the same as knee arthroplasty patients. When we look at a more generalizable population, so not the randomized clinical trial population, these data from Patrick Tai at the University of Florida, just published recently in Anesthesiology, are very relevant. In this group of several hundred patients having all kinds of surgery, you can see 5 distinct patterns of pain trajectories. Only one of those, the dashed line, is a steep trajectory over the first few days after surgery that declines down to almost no pain by 5 days after surgery, whereas the other 4 trajectories tend to actually have a slower decline in pain resolution. And 2 of those trajectories you can see from the top, the highest one tended to maintain severe pain for a week, whereas the second trajectory underneath that tended to at least be moderate pain for a week. And the factors that were identified were more phenotypic or patient individualized characteristics as opposed to procedures. And so we can at least conclude from these data, plus the data I showed you earlier, that within a general population, many patient factors affect the pain experience for any patient having surgery. And within a homogeneous population, the different types of procedures can predict different types of pain trajectories as well. And so we can't generalize how long any patient should require opioids. This is going to be an individual decision based on how patients respond to surgery. And so I think it goes without saying, when we look at how we design short stay recovery programs for any type of surgery, including hip, we go back to this list from the article I mentioned in the earlier symposium. If we look at the elements of an outpatient or short stay joint replacement program, it is essential that we have anesthetists who are skilled in regional anesthesia and can manage acute pain using a multimodal approach. And I think when we look at multimodal analgesic protocols, we need to make sure that these are checklists and not recipes, that we have to make it simple for clinicians and for patients so that way we can have these types of shared decisions. We need to look specifically at the agents and interventions, including non-pharmacologic techniques that should be used routinely for all patients, as well as look at certain categories of medications, including opioids, which can be safely prescribed, but should be used only when they're indicated. In terms of guidance at discharge, and I think this is a stretch for many anesthetists and acute pain physicians, we need to provide recommendations to our surgeons if we're not prescribing opioids ourselves as to how many pills patients should go home on. And these recommendations from the Michigan Open Group, this is led by Dr. Chad Brummett in the University of Michigan, provide at least a starting point for a conversation with patients and surgeons about how many pills you should start with. And these are based on opioid naive patients and not patients on chronic opioids. What we did in our practice was a little bit more patient specific. So we took patients going from inpatient care to outpatient care and used their prior 24-hour use to guide our opioid prescriptions, as well as tapering recommendations. And if you look at the figure that I showed on the left, using patients' maximum 24-hour opioid use for the day before discharge, you can plan a whole opioid prescription in terms of number of pills and specific instructions for how much to taper every couple of days until patients are off their opioids. And this has resulted for our practice a reduction in opioid prescribing dosage of up to 2/3 for various major types of patient populations like knee arthroplasty, hip arthroplasty, as well as spine surgery. And I think it's critical that we look at ways to reduce opioid-related harm across the board. And this is an important article, an international consensus statement we published in Anesthesia that just provides a list of modifiable risk factors, as well as different recommendations that we can implement at every level of the healthcare setting to try to decrease opioid-related harm for surgical patients. And I think it's key here that we use multimodal analgesia, which you've already mentioned, but at the same time, I think we have to identify patients who are on abnormal pain trajectories. And I think when we start to prepare patients for discharge, we have to make sure that we limit the number of tablets and give them good instructions for opioid tapering, as well as safe use, storage, and disposal of opioids. We have plenty of opportunities to improve. And as I mentioned, we have that several weeks after surgery is really a key time when we can intervene and try to decrease patients' risk of long-term opioid use. And in the end, I think the goal really is to try to personalize pain medicine. I think that from the data that we already have, we know that not all pain is the same for all patients. And so as our ability to identify risk factors gets better, we'll be able to better individualize our care plans based on preoperative screening and identifications of patients at risk. Thank you so much. Back to you, Kareem.